It's your first day of clinicals. Your instructor turns to you and says, "Go ahead and perform a complete head-to-toe assessment." And your mind goes blank. Where do you start? What do you check first? What if you forget something important? Every nurse has stood in that room. Today, I'm going to give you a simple, step-by-step system so you can perform a confident head-to-toe assessment every single time. A head-to-toe assessment isn't about memorizing a checklist. It's about learning to recognize what's normal, spot what's abnormal, and identify the patient who is getting worse. That's the difference between collecting data and thinking like a nurse. And here is why the order matters so much. When you assess in the same sequence every time, you stop relying on memory in the moment. The sequence remembers for you. That protects your patient from the system you would have skipped on a busy morning, and it protects your checkoff because your instructor is watching for a student who moves with a plan. Think about what a skip system actually costs. It isn't the missing line in your charting. It's the finding nobody had yet. And the finding you don't have is an action you don't take. So the problem keeps moving while everyone assumes it's being watched. Time is the thing you lose, and time is the thing your patient needed most. So today, you're going to learn the systematic approach experienced nurses use at the bedside. Same order, same thinking, every patient. Let's start with the framework. Use the Nurse Whiz Head Framework. H. Hello and history. Introduce yourself, verify the patient, explain what you're doing, and assess orientation and chief complaint. In the room, that sounds like your name, your role, 2 patient identifiers, 1 plain sentence about what you're about to do, and a question that lets you hear how your patient is thinking today. Ask an open question instead of a yes or no question, because the answer gives you speech, orientation, and effort all at once. E. Evaluate every body system. Move head to toe without skipping systems. If the chief complaint pulls you toward one system, finish the whole walk anyway. The finding you weren't looking for is often the one that changes the plan. The patient admitted for one problem still has every other system in the bed with them. A. Assess for abnormal findings. Compare both sides, look for changes, and recognize red flags. Abnormal isn't only what appears on a textbook list. Abnormal is also what's different from this same patient an hour ago. That's why you read the last shift's assessment before you walk in, not after. D. Document and decide. Record your findings, identify priorities, and plan your next intervention. Documentation is half the job. Deciding is the point of it. If your charting doesn't lead to an action or a reassessment, you stopped one step early. This simple framework keeps your assessment organized and helps prevent missed findings. Now let's walk the body. Before you touch your patient, simply observe. Your first assessment starts the moment you walk into the room. Look at level of consciousness. Assess orientation to person, place, time, and situation. Look at general appearance and hygiene. Look for any signs of distress. Listen to how your patient speaks. Let's make that concrete. Level of consciousness. Normal is a patient who is awake, who looks at you when you speak, and who answers you without being shaken awake. Concerning is the patient who needs repeated prompting, who drifts off mid-sentence, or who is suddenly agitated when they were calm before. Orientation. Ask their name, where they are, what day or time it is, and what brought them in. Normal is all 4. Concerning is when one of those slips, and it's more concerning when it slipped since your last assessment. Appearance and hygiene. You're looking at grooming, clothing, and whether the patient can care for themselves. It tells you about their function at home, not just their diagnosis. Distress. Look at posture, facial expression, and how they're holding their body. Comfortable looks relaxed in the bed, shoulders down, face easy. Distress looks like a furrowed brow, a hand guarding one spot, restlessness, or a patient who won't lie back. A patient sitting bolt upright, gripping the side rail, is telling you something before they say a word. Speech. Normal is clear, steady, and in full sentences. Concerning is slurred, garbled, one-word answers, or a patient who has to stop and breathe in the middle of a sentence. And compare all of it to report. Alert and oriented is a good finding. Alert and oriented in a patient who was oriented to all 4 this morning and is now missing one is a change, and change is what you're hunting. A normal picture looks like this. Your patient is alert, they're oriented, they're speaking clearly, they appear comfortable. You gathered all of that before you ever put a hand on them. Next, the neurological system. Check the pupils. P-E-R-R-L-A. Pupils equal, round, reactive to light, and accommodating. Once you know PERLA, you check it the same way every time. Assess facial symmetry. Assess speech. Check hand grips. Check arm strength. Check leg strength. Check sensation. Here's the flow at the bedside. Pupils first. Then ask your patient to smile and raise their eyebrows and watch both sides of the face move together. Then listen to their speech while they answer. Then hold out both of your hands and ask them to squeeze. Then arms, then legs, then sensation. For strength, you don't need fancy language to be useful. Ask them to squeeze both of your hands at the same time, then push and pull against your hands with their arms, then push against your palms with both feet. You're describing 2 things. Is it strong or weak? And is it equal or unequal? Strong and equal on both sides is your normal. Weak on one side when the other side holds steady is the finding you carry out of the room. For sensation, ask them to close their eyes while you touch each arm and each leg, and ask whether they feel it and whether it feels the same on both sides. Numbness, tingling, or a side that feels dull compared to its partner all count. Normal is symmetric. Both pupils the same size and both reacting. Both sides of the face lifting equally. Grips that are strong and equal in both hands. Equal strength when they push against your hands with their feet. Abnormal is one side that doesn't match the other. Your red flags here are unequal pupils, facial droop, slurred speech, and weakness. Your priority is to immediately recognize possible neurological emergencies, and this is where you have to know the difference between new and old. A patient with long-standing weakness from an old injury has a baseline, and that baseline belongs in your report. Sudden is the word that changes everything. A deficit that wasn't there an hour ago is treated with urgency, not curiosity. This is why bilateral comparison matters more here than anywhere else in your assessment. A weak grip on its own can be a lot of things. A weak grip on one side with a strong grip on the other in a patient who was equal this morning is a different conversation entirely. The patient is their own control. Neuro changes are quiet at first. You will only catch them if you look for them the same way every shift. Now, respiratory. Assess respiratory rate. Assess breathing effort. Assess chest expansion. Listen to lung sounds. Check oxygen saturation. Look first, then listen. Count the rate for a full minute while the patient isn't thinking about it. Watch the effort. Are they using accessory muscles, sitting forward, breathing through pursed lips, or can they talk to you in full sentences without pausing? Watch the chest rise and confirm both sides expand together. Then listen. Skin, not gown. Move your stethoscope side to side, comparing left to right at each level, and work from the upper fields down to the lower fields, front and back. Side to side is what makes the comparison honest, because you're listening to one lung against the other at the same height. Ask your patient to breathe in and out through an open mouth, and give them a moment if they get lightheaded. Normal lung sounds are clear. Abnormal lung sounds are crackles, wheezes, rhonchi, or absent breath sounds. Crackles sound like popping or fine Velcro. They show up most often at the end of a breath in, and they point you toward fluid in the small airways. Wheezes are high and whistling. They often stretch across the breath out, and they point you toward narrowed airways. Rhonchi are low and rattling, closer to a snore, and they often clear or change with a cough because they come from secretions in the larger airways. Absent breath sounds mean you are hearing nothing where you should be hearing air move, and that is the one that gets your attention fastest. Then check the oxygen saturation and read it alongside the work of breathing you just watched. A number by itself isn't an assessment. A saturation that looks acceptable in a patient who is using accessory muscles and speaking in 3-word sentences is a patient spending everything they have to hold that number. Your priority here is simple. Always assess breathing before moving on. Breathing is never the system you save for later. Next, cardiovascular. Assess heart rate. Assess rhythm. Listen to heart sounds. Check peripheral pulses. Check capillary refill. Check skin temperature. Check for edema. Listen at the apex and count the rate. Note whether the rhythm is regular or irregular. Then move outward. Palpate the pulses on both sides and compare them, because a pulse that's strong on the right and thready on the left is telling you about circulation to that limb. Check the radial pulses together, then move down to the feet and compare those the same way. Press the nail bed until the color blanches, release, and watch the color return. Brisk is a return in about the time it takes to say the word. Delayed is when you're still waiting and wondering. Put the back of your hand on the skin and feel for warm and dry versus cool and clammy. Then press over the ankles and shins for a few seconds and lift your fingers. If your fingertips leave a dent that stays, that's pitting edema, and the question that matters most is whether it's new. Good perfusion looks like warm skin, brisk color return, and equal pulses you can find without hunting. Poor perfusion looks like cool, pale, or mottled skin, sluggish refill, and pulses that are hard to feel. Your red flags are chest pain, weak pulses, cyanosis, and new edema. Your priority is to assess circulation and identify poor perfusion. Notice how the systems build on each other. Breathing moves oxygen in. Circulation carries it where it needs to go. Now, gastrointestinal and genitourinary. Inspect the abdomen. Listen to bowel sounds. Assess for tenderness. Assess for distension. Ask about nausea. Ask about the last bowel movement. Check urinary output. The order here is different from the rest of your assessment, and that trips students up. You inspect, then you listen, then you palpate. Pressing on the abdomen first changes what you hear afterward, so you'd be listening to sounds you created. So look at the abdomen. Is it flat, rounded, firm, or visibly swollen? Then listen in all 4 quadrants before you touch, and give each quadrant real time instead of a courtesy second. Bowel sounds that are diminished or absent make you think about movement that has stopped, and that points you toward obstruction and toward a patient who shouldn't be eating until someone with more information says so. Then palpate lightly, watching your patient's face while your hand moves, because their expression will tell you about tenderness before their words do. Then ask, any nausea? When was your last bowel movement? Are you passing gas? When did you last urinate? And check the output, both the amount and the color. Small amounts and dark, concentrated urine point you toward dehydration. A patient who feels the urge and can't go points you toward retention. Your priorities in this system are recognizing obstruction, dehydration, bleeding, and urinary retention. These are the findings patients don't always volunteer. You have to ask. And finally, skin and musculoskeletal. Assess skin color, temperature, moisture, and integrity. Look for pressure injuries. Assess strength, assess mobility, assess fall risk. Integrity means you actually look. Check the sacrum, the heels, the elbows, the hips, the back of the head, and under anything that presses. Oxygen tubing behind the ears, the edge of a brief, compression devices, and lines tucked under a shoulder all sit on skin for hours. Redness over a bony area that doesn't fade when you take the pressure off is your early warning, and early is the entire point. Pressure injuries are far easier to prevent than to heal, so you're looking for them before there's anything to stage. Then assess how your patient moves. Can they sit up, bear weight, and steady themselves? Do they reach for furniture? Are they weak on one side? Watch for the cues while it's happening. A patient who sways when they stand, who takes a long moment to get steady, who needs both hands to push up, or who is barefoot on a slick floor with the call light out of reach, is telling you their fall risk in real time. And the strength you graded in your neuro exam is the same strength holding them up here. So unequal strength and unsteady mobility belong in the same sentence. Your red flags are pressure ulcers, poor circulation, weakness, and limited mobility. This is the system that protects your patient from the harm that happens after admission. Let's take everything we just learned to the bedside. Your patient is 68 years old, admitted with pneumonia. Temperature is 101.8 degrees Fahrenheit. Respiratory rate is 28. Oxygen saturation is 89%. Lung sounds reveal crackles in the bilateral lower lobes. Heart rate is 112. What assessment finding concerns you the most? Pause and think. Let's walk HEAD. Hello and history. You introduce yourself, you verify your patient, and you explain what you're about to do. You assess orientation, and you ask about the chief complaint. Your patient was admitted with pneumonia, so respiratory is already on your mind before you touch them. And listen to how they answer you. A patient who can't finish a sentence without stopping to breathe has just given you a respiratory finding during the introduction. When your patient is short of breath, keep your questions short too. You are not trying to get a full history out of someone who is spending every breath on breathing. Ask what you need. Watch how much effort each answer costs, and let that be part of the assessment. Evaluate every body system. You move head to toe and you don't skip. General appearance gives you work of breathing. Respiratory gives you a rate of 28, crackles in both lower lobes, and an SpO2 of 89%. Cardiovascular gives you a heart rate of 112. Your temperature is 101.8, and yes, you still finish the walk. Respiratory is loud here, and the temptation is to stop the moment you hear it. Keep going. Skin, abdomen, output, mobility. That takes very little time, and it's what tells you whether this is one system in trouble or a patient in trouble. Assess for abnormal findings. Compare both sides. The crackles are bilateral in the lower lobes. Look for changes. The respiratory rate is elevated, the oxygen saturation is low, and the heart rate is fast. Now recognize the red flags. An SpO2 of 89% with a respiratory rate of 28 is a patient who is working hard and still not oxygenating. Now sort them. You have 4 abnormal findings, and students want to treat all 4 as equal. They are not. The fever matters. The heart rate matters. But the fever and the tachycardia are consistent with the pneumonia you already know about. The oxygenation is the finding that will hurt this patient first. Think about the direction each finding is pointing. A temperature of 101.8 in a patient admitted with pneumonia is expected. A heart rate of 112 in a febrile patient who is breathing hard is expected. Neither one surprises you. The crackles are expected too, and they confirm the picture rather than change it. But a respiratory rate of 28 tells you this patient is spending real effort to breathe, and an oxygen saturation of 89% tells you that effort isn't working. That is the finding you did not already have an explanation for, and it's the one with the shortest fuse. So rank them out loud. Oxygenation first because it threatens the patient soonest. Work of breathing right behind it because the two live together. Heart rate next because it's the body answering the oxygen problem. Fever last because it's expected, it's being treated, and it isn't what changes your next 5 minutes. Document and decide. You record your findings accurately. You identify your priority, and your priority is airway and breathing. Then, you plan your next intervention and you escalate. This is not a finding you chart and revisit later. In practice, deciding sounds like this. Position your patient to support their breathing. Apply oxygen per your unit's protocol or provider order. Notify the provider with the findings you just gathered. Then stay and reassess, because the next set of numbers tells you whether what you did worked. Reassessment is not a formality. It's the only way to know whether you fixed the problem or just documented it. A complete assessment isn't about collecting information. It's about recognizing what requires immediate action. Here's your NCLEX tip. Remember 5 words. Look, listen, feel, think, act. Look at your patient before you touch them. Level of consciousness, work of breathing, color, distress, and how they're positioned in the bed. Listen to lungs, heart, and bowel sounds, and listen to your patient's voice while you do it. Feel pulses, skin, and abdomen, and compare left to right every time your hands move. Think about what your findings mean together. One abnormal number is data. Several abnormal findings pointing the same direction is a picture. Then, act on the finding that threatens your patient first. Run it once on a generic patient. You look and you see someone sitting forward, working to breathe. You listen and one side sounds different from the other. You feel and the skin is cool and the color is slow to return. You think, and every one of those findings is pointing at oxygen and perfusion, not at four separate problems. So you act on breathing and you escalate, and then you look again. That's the whole loop, and it works on any system. The NCLEX does not expect you to memorize every possible finding. It expects you to recognize abnormal and to know what to do next. Let's bring it home. Your key takeaways. Follow the same assessment order every time. Compare normal versus abnormal findings. Observe before touching the patient. Prioritize airway, breathing, and circulation. Always document accurately. Treat the patient, not just the assessment findings. A great head-to-toe assessment builds your confidence, it improves patient safety, and it helps you recognize problems while they're still problems, before they become emergencies. Same order, every patient, every shift. Don't forget to like and subscribe to the Nurse Wiz channel.